start with what I had intended to present, and if it dovetails nicely with something you've already heard, fantastic. If you have additional questions, we can reach into those subjects too. So I had asked for everybody to come prepared to participate in more of a dialogue or discussion, because I think that tends to open up the conversation a little more and get more information presented. So one of the first things I had asked people to review was a quick website that just talks about what is telemedicine, what is telehealth. So can one person or two people shout out kind of what they define as the telemedicine or the practice of telehealth? Anybody? Yes?
It's using telecommunications to make healthcare processes more efficient and convenient.
Exactly, exactly. So telecommunications is a huge piece. The other one is kind of this time-space definition, which is oftentimes that you're remote to the provider that is providing services from the patient perspective. So it's using telecommunications, and it's this factor that you're not in the same time and place, or at least not in the same place. It could be the same time. There were 4 specific types of telemedicine or telehealth that were on that website. I asked you guys to briefly look at. Can you by name tell me what they are? Yes?
mHealth?
Yes. And what is mHealth?
It's like using a mobile device to provide help for people, so like cell phones or things like that.
Right. Can you give me an example of mobile,
Um,
where this might be used?
in one of my public health classes, we talked about using it in like third world countries so that people can reach physicians when they're in an area that doesn't have medicine.
Absolutely. So using some type of mobile device, maybe cellular device. It's unbelievable, actually, in the third world countries, while they may not have broadband or an internet service provider, they actually have quite a bit of cellular function. So it's neat that they had that opportunity now to get that for healthcare. Another example with the mobile health is in kind of the public health space again, looking at notifications that need to go out to broad audiences or broad individuals in the community. So say, for example, there's an outbreak of hepatitis A, and you need to notify your community, anybody who's eaten at the Village Inn last week or wherever it may be. This is one way where you can communicate broadly with anybody in that area code or that network to try to reach out to people. What was another type of telehealth provided on the website? Yes?
Remote patient monitoring.
Exactly. Remote monitoring. And what does that entail?
At least from like looking at this and from my knowledge, it's like I think it would be like, say, like a heart monitor, like the doctor is able to like get the information about like the patient's health like in real time, I guess.
Absolutely. So the patient's somewhere at home, we hope, in the community doing what they want to do with their day, but they've got some device or some ability to collect data that then is provided back to some provider, physician, clinician, somebody to look at that and review. Holter monitors, huge. This has kind of revolutionized the way we can provide some home cardiac care with detecting some of those rhythm abnormalities in a setting where the patient may be at home. What were the other 2? Anybody? Yes?
So Snorri Forward,
Yep.
and the AAD article also talked about this, the fact that you can like take a picture of something and then send it off to be analyzed or read by a professional, so a physician in those cases.
Exactly, exactly. So the other term for this is asynchronous. Asynchrony being not same time, same place. In complement or in contrast to it, what's the other 4th type of telemedicine now that's not asynchronous?
Synchronous or live.
Right.
The fact that you can like see the doctor real time and have a conversation with them.
Right. So live video interactive. So those are kind of what I group as the 4 main types of telemedicine, and where each of them is used. mHealth, we talked about the mobile devices, trying to reach a big community quickly. Remote monitoring, where you may have a patient who needs to get data back to a clinician or provider. You might also have a group of patients that you're going to monitor their data, and the provider's off-site. So if you think about from the ICU perspective, maybe we're collecting a lot of data on these ICU patients, but the intensivist isn't actually in the hospital, and they can log in and they can see, well, what are my patient's blood pressures doing? Do I need to ask my on-site physician or my on-site nursing staff to assist with their care? Store and forward is that asynchronous. So the classic case is that you've got some data that's being collected. It's all being uploaded into some cloud or some storage facility, but then it's being accessed at a later date and time by the physicians. And then lastly is the live video interactive, where you've got a patient at one site, you've got a provider at another site, and they're video conferencing so they can provide care in that manner. What might you think could be some pitfalls or some potential benefits, which we've already touched on, of each of these? Where would it be good or where would it be less good to use this, for example, store and forward? Yes?
So I think it's very clear when you think about a lot of these diagnostic procedures, and you have, generally there's long wait times. You can call in, make an appointment to be seen for a little skin abnormality, and it could take a very long time for you to actually see a doctor. Meanwhile, there's times where I'm sure from the other end, the physician is sitting there and they wish they had the patient come in at a certain time, and that patient just doesn't show. So it's a matter of matching up the excess capacity with the actual things for them to for doctors to actually analyze.
Right. So access is one and convenience is another, right? So here we've got a whole lot of patients with very few providers. But we've got lots of providers 4 counties over. How can we provide care in that setting? You can do this. Convenience? Absolutely. If I'm out on the weekend and I've got stuff going on and I want as a patient to be able to get care, perhaps I'm okay with putting all the information in and then waiting till the weekday when my doc's back in the clinic to read it between patients that are seeing. It's not urgent, but it'd be nice if they could read it. So that's another one. What about pitfalls? What might the problems be with store and forward?
I know that some apps, like for like dermatology, where you can take a picture and then send it to a dermatologist, and they can like tell you, oh, that's a condition you do need to probably go see an actual dermatologist. Like it's not, usually the image isn't able to give a secure diagnosis. It's just like, here's advice or something.
Right. And we'll talk about kind of the 2 ways that I think about store and forward or asynchronous care being provided. So one is where you actually do have management. I see it, I know what it is, you just need some medicine, I can prescribe it, you pick it up at the pharmacy, you move on. Or what you're mentioning, triage. I look at it, I say, well, I think I know what it is, but I need some more testing, or I need to see you in person, or maybe I want you to try something first and then come back. So I'm not able to kind of wrap it up all nice and neat and have a diagnosis and a treatment plan all in mind at that time. Perfect. What are some other pitfalls of store and forward? If you think about your typical traditional in-clinic office visit, what happens? When you go to the doctor, what do you do? Yes?
Yeah, so one thing that I found very interesting was I'd never thought about the physician-patient relationship and how that needs to be established prior to an ongoing sort of relationship. So I think when you actually go to see a physician in person, you're establishing that relationship, and they're on forward. Basically, the doctor is liable for any diagnosis that they make. Whereas store and forward, if you don't have that existing relationship, you need to establish it somehow prior to in order to use the system.
Yeah. And I'll put that as maybe under all of them is this liability question mark. How does each of these work in our standard clinic setting right now, and what happens if something goes wrong? Or what happens if you don't get all the complete information? How do we handle that? I don't think we know yet. This piece is still kind of being defined. Looking back again at that initial clinic visit, with or without that predefined physician-patient relationship, when I first walk into the doctor, do I walk in with my piece of paper and it says, these are all my symptoms, these are all my medical problems, these are all my medicines I take, all my allergies, this is what I think I have, can you help me? No. Very, very rarely. So what does happen in the clinic? How do I get that information?
You ask questions.
Bingo. You ask questions. How do I do that with store and forward? Can I do it with store and forward?
If you include a questionnaire, maybe.
Right. can include a questionnaire, so I can be very directive. I can say from the onsite, oh, looks like you want to come see me because I'm a dermatologist for a rash. So the questions that help me define what your rash is are these, 5 or 6. So I'm going to send you a questionnaire when I know you're coming to see me for a rash through this method, and you answer them. And then I get a lot of the information I would otherwise ask. What if I don't? Does that mean this is off the table? I can't ever use it? Who says yes? If I can't ask questions, if I can't have a dialogue, I can't do store and forward. Who says no? You can still do it. Good. I hope I see a lot of hands in the room, because I'm going to guess you guys have all used text messaging back and forth with somebody over some point in time, and you do it, right? You're not in the same time, you're not in the same place, you're not doing live video interface, you're not on the phone talking live, but you're sending text back and forth, right? So it's the same type of deal where I ask you a question, it goes up, it's stored someplace, I get it or access later, right? Back and forth. So store and forward may lengthen the procedure, the dialogue becomes difficult, you don't have that immediate question answer back and forth, but it's not impossible. You just have to find ways around it. It may mean that you're lengthening the time at presentation of case to solution or resolution of case, because you need to get those questions asked, you just have to find another way to do it. What about live video interactive? So this is a little different, I do have that opportunity for dialogue. What are some of the pitfalls or conveniences of this? I now don't have convenience so much, right? I've got the same thing where we're in the clinic, or at home, and we're in the same time. At 2 o'clock we're going to connect and we're going to be on the video together and we're going to talk about patient problems and my fixes. But what might it benefit? How is this good?
I mean, you don't have to be in the same place at the same, like you can, it's at the same time, but it's like if you're traveling or if you're like going somewhere else, like you can still help them.
Right. So I still have space convenience, and that's a bonus. Anything else? What about my access? Does it improve my access? Absolutely, right? So I still have doctors in one place, patients in some other place, but now I've got a solution for them to see us. So that's good. Problems with this?
I'm just thinking connectivity issues.
Bingo. Huge, huge problem, right? So I said third world countries, cellular, mobile health, a lot of them have the networks, that's fantastic, but they don't all have the broadband. So if I'm relying on any type of internet service provider or broadband access, connectivity is huge. How many of you are happy when calls get dropped time after time after time after time again? Right? It doesn't make the patient happy, it doesn't make the provider happy. It's really frustrating. So it's something you got to plan for ahead of time. You have to establish all those connections in that network beforehand. What about remote monitoring? We talked about some ways where we could use it. Either lots of patients in an ICU and a physician's off-site who's kind of looking at the numbers and the data, tracking people over time. Or the reverse, I'm sending patients home with some device and they're off in the community doing what they want to do and I'm just looking at the data as it comes back. Any other benefits, downsides for remote monitoring?
I mean, the one downside I see is like, yeah, you can see numbers and stuff, but like the actual, like the visual that you see, like that can also show you a lot about their health condition at that time.
Absolutely, absolutely. How many of you guys in the room have a Fitbit? How many? Couple hands? Couple? Okay. How often are you looking at your own individual data for steps tracked or heart rate monitoring, whatever it provides back to you? Whenever it sends notifications. So that would be an ideal type of remote monitoring if you preset some type of alarm and then it notifies you when that threshold's met. Yep.
When I first got it, like pretty often.
Yep.
But I don't wear it anymore, but after about a year I would really only check like when my friend brought it up.
Mhm.
Or if I was like, oh great, yeah, I have a Fitbit on it to see how many steps I've got, but I really definitely stopped checking like a few months after the novelty
Yep.
of having something that tracked for you
That's not unusual. I think we all have this kind of, it's a new device, it's really cool, it gives me instant feedback, instant gratification. I'm gonna use it, and then they have shown over 6 months start to lose wearers, lose individuals' interest in kind of some of those devices. So with remote monitoring, data is huge, and it's both a plus and a minus, right? Because I need to know the reliability of my data. What does it all mean? What if I've got a lot of heart rates that come back in the middle of the day, sky high? This patient's heart rate is like he's running a marathon, right? And I don't know what he's doing. And it turns out he's laughing hysterically with his son, rolling around on the floor. He's totally fine. I need to know some other piece oftentimes with the data that I'm getting to make it meaningful. When you get a lot of data, especially with Fitbits, you've probably heard or seen some of the conversation. Physicians are already under this data deluge. They already have tons of information. So if we're going to do remote monitoring and you're going to start sending me a whole bunch of additional points on my graph, wow, that's a lot of information. And I'm having a hard time keeping up with the stuff I need to review already. So how do I accommodate for the extras? The negative side with remote monitoring, you don't have that extra time piece or that extra piece of data. But what if you could build it? What if you could say to patients, hey, I'm monitoring or I'm watching you for this. You tell me what's happening hour by hour. Keep a calendar. That could be useful.
Yeah.
Right? So there are ways to work around it. Mobile health. Any thoughts? Good, bad, benefits, downsides?
There are just so many apps that I think maybe sometimes it's hard for like consumers to pick like, oh, here are the best apps for what I want or what I want to be educated on.
Right. App deluge. There's a lot of stuff out there. How do I know it's reliable? How do I know it's right for me? How do I know it's going to do what I want? What does it do? Lots of questions around that. What about if we look at the public health perspective, where there's some outbreak or there's something that they want to control, and they start pushing notifications out? Zika virus, right? We'll make it relevant, we'll make it current. So going into mosquito season. What if my public health department gets together with my local policymakers and says, anytime, anywhere a mosquito is seen, we're notifying the community. Anytime. Because that could be the Zika mosquito. What's going to happen with mHealth, with those notifications going out, if those changes are made? Are we going to be happy about it? Probably not. Many of us wouldn't be. Some of us would be thrilled. Right? Mosquito sighting. Show me where he is. I'm going to get him. The problem is fatigue. Alarm fatigue, notification fatigue. If you start getting too many notifications, they start losing their value. Because then I'm notified about everything. But from a public health perspective, it offers a great benefit. Kind of like the Amber Alerts. You've gotten those on your phone or the radio switch over. Be aware. Let's work communally and see if we can fix this problem. If we can work communally and fix an outbreak before it got Ebola status, that would be fantastic. Okay? So, just touching on these, where each of these may go. Now, we talked about this, a liability perspective, which kind of touches on each of these, because we're still pretty early in the infancy of this development. We don't really know how it's going to work just yet, right? What other problems, alongside liability, might apply? What else happens in a physician visit?
I mean, when you actually see a physician, like you're in like a closed room, it's like privacy, so like HIPAA compliance with like apps or like any like, tech-based.
Yeah. HIPAA, definitely. Privacy. Who knows the event that happened recently at MedStar? It was in the news this week. Anybody? Okay. So MedStar is a collection of hospitals, or probably more than just DC local, but DC local hospitals. And much like some other facilities recently that have been hacked, they got hacked. Some of their data was taken for a short while, right? Someone else had ownership of it and wanted to ask them to pay money for it. Privacy and security of data is huge, right? And we've seen big hospital systems with decades of experience, with well thought out, good, what I probably pretty secure platforms have problems. So every time each one of these is developed, are they all holding to that same standard for our data security and privacy? I really hope so. I really hope so. But it's a problem, we gotta think ahead for it. What else? I go to the doctor, I don't have my piece of paper, I'm actually gonna have a dialogue with them, and then I'm gonna leave. What next?
I would also say that there's obviously some form of payment involved, whether you realize it or not. So insurance are they gonna reimburse these forms of care or are they not?
Exactly. Reimbursement. Okay. It's a pretty big one. Because right now there's a pretty set of kind of standards or rules that we follow. I contact my insurance company, I say I need to see a doctor. They say these doctors are in your network. If you go there, we'll pay X, you'll pay Y. I say okay. Call the doctor, I schedule my appointment. I leave and I pay my bill. Either my copay or my cost of services, whatever it may be. But we don't really have that structure set up yet. We don't really know what the reimbursement is going to be. I think we're moving into this pretty rapidly, and I think some of that's being defined pretty quickly. But it's not 100%, and I'm sure it varies, insurance by insurance, state by state.
So then, how do you usually charge when you do these like telemedicine?
Everybody's different.
Okay.
Everybody's different. What else is going to maybe be a problem, or maybe be something to think about? I'm a physician. I live here in California. I see patients largely in California. We all agree that that's okay. But who tells me it's okay for me to see patients?
The California Board of Medicine.
Right. The California Medical Board. So what does California say about patients that I see in my home state of Missouri? Anything?
I guess being Missouri law has jurisdiction over those patients.
Right, right. For the most part, California isn't really involved. But Missouri is intimately involved, right? Because they want to make sure that their patients are protected and that they get good care, and that providers practice by their rules. And it's not the same, right? Some rules in California are specific to California, and some rules in Missouri are specific to Missouri. So there's the kind of legal piece of practice with the medical boards. Okay. Excellent. So who wants to tackle one of these? How are we going to fix this problem? Or set of problems? We're in a room and we've been tasked tonight with a complete overhaul of our medical system. It's entirely up to us. So one by one, we're going to pick apart our problems with making this set of systems work. But we got to do it one at a time. What are we going to do about liability?
Maybe have the patient sign something beforehand, so like the doctor is like protected.
We could do that. We could have the patient sign a waiver, push off some of the liability. I'm going to do my best, Hippocratic oath, I'm going to treat you right, but I'm going to have you sign a waiver so that we're kind of under the same agreement. I could do that. What else?
Maybe establish a company that provides supplemental insurance to doctors who are already paying for malpractice insurance, but this particular subset is for telemedicine.
Absolutely. We could open up a whole new branch of med malpractice. This could either be an add-on, maybe it's something I purchase in addition because I'm doing some telehealth. Maybe we decide it's lower risk cases, so it's less than my typical insurance. Maybe we decide it's a real risky way to pursue care right now because we don't have all the details worked out and it's more expensive. But absolutely, we could come to terms on some type of medical malpractice and use that for our telehealth practice. What else? say I'm company A, and I'm trying to recruit physicians into my practice, provide this new type of telehealth care. So one of the perks I may have is that I'll pay 90% of your telehealth malpractice. I'll take company A to pay for part of it, right? Company B, however, they know what company A is doing, so they're gonna say, I pay 100%. Right? That's free market economies, that's capitalism, right? I have a good, they want my good, so they're gonna battle out to provide me a better deal to try to get me to join their service. Right. Yeah, so we could absolutely see some companies that offer some perks and benefits. The other thing that could happen, company A says 0%. Company B says, yeah, they're not doing it, we don't have to do it either. Nobody's gonna cover it. So then who pays for it? Is it the physician? Maybe. Who else might pay?
The recipient, so I almost think about like the Uber model, when you're paying to ride an Uber car, it's like $1 or something of that goes towards covering the driver
Exactly.
insurance.
Yeah. So it could be that the physician pays, it could be that the patient pays in some way, right? Because if I have a service I want to provide, and I have limited overhead, I want to try to keep my overhead low, my profits high, that's business, then I need someone else to take a part of that cost. So it could be that it prices the service I provide because some of it's passed off to the patient. But anybody could, right? The company could take it on, the physician could take it on, the patient could take it on. And depending on how your business model is set up, how your exchange of goods and services is worked out, it could be a mix of all, or predominantly one. Good. So that's a nice look at liability. And I think some of this is still being defined because we haven't had a lot of services provided like this just yet. Telehealth, while it's been around for decades, finally has all the right pieces aligning where the technology is good enough, and the providers are pushing for it, and the patients are seeing increasing healthcare deductibles and a change in the way they care for themselves and take onus of cost, so they're a little more amenable to it. But we haven't done it long enough to start having liability issues come up, and at some point, unfortunately, we probably will. So this is TBD. I think for most individuals who choose to practice telemedicine, there is at some point, the mindset for what is my liability myself, and what is my protection, and so medical malpractice becomes a big piece of that. I don't know that too many companies are yet doing waivers, but it's an option. It's an option. I would wonder what the legality of it would be. Would it stand up in the court of law? Because despite my best efforts to practice good medicine, solid medicine, I don't know. I'd still want to protect myself just in case. What about the HIPAA and the privacy and security? How are we going to overcome that?
So I feel like technology is kind of the answer to this question inherently. When you look at other industries that have converted over to mobile, let's say like the financial industry, I think people tend to value their financial information and guard it closely. But we've seen that technology's kind of overcome a lot of those barriers where now you can do mobile banking, and a lot of that I think is really the, like, I don't know, this is way out of my lane, but like encryption and secure networks that make that data difficult for thieves to get at.
Right, right. I am not a technologist by training. I have no background in computer science. I have really little idea of what it takes to make a system super secure. But I recognize it's probably quite difficult. So this, I rely heavily on my builders, my technologists, to build to specification, because there's, at some point with HIPAA, with government policy, some standard that we have to meet. But but also from a privacy security, that they're patching the holes and making sure that there's as few ways as possible for that data to be compromised. So it's not insurmountable, but it's difficult. And just like every lock over time, someone's gonna find a way to pick it. We kinda always have to be thinking ahead. Because unfortunately, as you build these mega bases of lots of patient information, and not just by medical records, but also some of your financial information, for billing and things like that, you need to make sure it's well protected. What about from the payment and reimbursement perspective? Yes.
Well, I figure that would just need a conversation with the insurance companies and the physicians, because at least like say for remote patient monitoring, I think there were some like challenges to like how the physicians reimbursed for like, I don't know, every hour that they look at the information.
Right. Yeah. It becomes a challenge because it's a different mindset. If you've been following healthcare recently, we're really struggling right now because we're trying to change from a system where a lot of our care was based on services. You see me in the office, it's this price. I do a biopsy, it's this price. I make an incision, it's this price. And switching over to value-based medicine. So what does that mean? I'm still cutting you, I'm still having to biopsy things, but how do I get paid? So we're trying to define what that means. Looking at some of the payment and reimbursements, some of it's not just the insurer. Who else might pay?
Obviously the patient.
Right, right? So there's this thing called direct to consumer versus the insurer, perhaps. So if I get medical care right now, this somewhat still holds in the clinic. I can go through my insurance, right? I can pull out my insurance card, I can present it at the beginning of my visit. At the end, I'll get some sort of bill or some sort of explanation of benefits back from my insurer saying you were seen on today's date, you had this done. It cost us this price of which you're responsible for this amount, right? So I can go through my insurer. Or I can also just go to a clinic and say, I've got a splitting headache and I need to be seen. And ignore that insurance stuff because I don't want to think about it right now. I just know I'm sick and I need help. And I can front all the expense myself. I don't know with all of your insurance how nice they would be about that because I think they want you to use the network that they've established. And I think you want to use that network because it would probably save you money. But you could actually still get services that way. So the same thing could hold true for telehealth, right? I'm a physician. I'm working with my technologists. I'm going to build myself a nice little telemedicine or remote monitoring platform. And I'm going to approach a bunch of insurers and I'm going to start asking, what should we do here? You can pay me $100 to see your patient in clinic, or you can pay me $80 to see the same patient online. Can we come to an agreement? The other way that this is done is through some employers. Because a lot of people still get their health insurance from their job. So it could be that I go to the employer group and I say, University of Berkeley, you employ a ton of people who have skin issues. Forget that dermatology in-office visit, your list of names. From now on, all of them come to me. And you pay me a specific price and I manage all of your employees' skincare. So there could be a negotiation that takes place at that level, thinking that the employer is serving somewhat as the insurer for that population. Okay. So we're still working on liability. We're going to build ourselves a nice, secure technology network. We're going to think about these different reimbursement models and figure out how we're going to get paid. Legal piece. What are we going to do about the legal piece? Is it even legal? Can I see a patient online? How many say yes? Okay. How many say no? It's legal, depending on where you are, right? I'm a physician here in California. The law is set up here in California that telehealth is an acceptable form of care delivery. But it's not the same in all other states, right? So this legal piece is actually practices in neurology, and he's made his practice the practice of stroke identification. Where do you go if you think you're having a stroke?
ER. To the ER?
To the ER, fast, right? Get there, get treated. So my colleague is only going to do stroke care. How in the world is he going to do that? He can't be in 2 ERs at once, let alone 200, 2,000. How is he going to pull it off? If you wanted to do just stroke treatment and you wanted to make your services widely available, how would you do that? What would it look like?
So I would contract with different ERs and say, hey, if you have a patient who comes in with these symptoms and you want a neurology expert on your ER staff that's on call 24 hours a day, contact me when you see a patient come in with these conditions.
Absolutely, right? I'm going to be a telestroke expert, and I'm going to approach different ER facilities, probably in regions where there's no neurology provider already on site, and I'm going to work out some type of negotiated agreement that says when you've got a patient that's presenting with these symptoms, and your options are transport, get them off site to another facility who has a neurologist, or make an action, consult me. This is all I do, right? I'm a teleneurologist tonight. So I'm going to identify for you stroke, not stroke. And anybody in the middle, I'm not quite sure, well then that small subset of patients, they need to be transferred someplace. Okay? So we're starting to see some ways that we can work around and provide medicine care differently, but we have to think about all these pieces. And I want to touch one more time on this.
That's not different than what's existing right now with radiology, right?
Absolutely.
Right, and that's legal in all the states, right? Teleradiology?
I would have to look myself. I think it's probably growing a lot.
Right.
I don't know if there's any place where it's restricted.
So like all these negotiations that you're talking about that they can just like randomly decide they want to do all these like this exact thing for one night, like would these have to be like approved by the medical board? Is that like one way they would regulate it to be legal?
Yeah, so that's what I was getting at, that one piece we need to talk about. So if I'm a teleneurologist and I want to practice in 15 different ER facilities, and not all states say it's okay for me to do that, I'm going to have to go to the states that say it's okay, so it's actually legal. But beyond that, I've got to have some sort of certificate from the medical board in each of those states. I've got to have a medical license of some sort, either a full license or a special tele-license, but some piece of paper that says it's actually legal for me to do this, right? So I can go to my hospital, I can get it all approved, but unless it's legal, my hands are really tied, right? And I made the remark, in California, they don't really mind so much what I'm doing in Missouri from a medical practice standpoint, but that's not 100% accurate. The problem is, if you get in trouble with one state medical board, the other states where you're licensed often want to know about it. And it may be a problem in their state too that you got into trouble over in state number 2 or 3 or 4, right? So that can become an issue, and as states are trying to figure out what constitutes telehealth, how much are we going to allow, what's not going to be allowed, individuals who are practicing in more than one state really need to pay attention to what the legal ramifications are, where they can do and what they can't do in certain areas. What about from a workflow standpoint? So we'll use the same case of the teleneurologist. And I'm here in California, and just because I grew up in Missouri, we'll use Missouri, and I've got a patient here in an ER, and I'm evaluating that patient for possible stroke. What are some of my possible outcomes? How am I going to get information from this hospital in Missouri? Are they going to send smoke signals? Hope not. Yeah.
Just like share live synchronous videos or if that's legal.
Yep. We can do video. So I can get lots of information that way. What might I agree. I think I'm probably gonna get a lot of history. Yeah?
Also do remote monitoring to like supplement the video, so you have the data.
Yep. So I'm gonna get a history from the video. What else am I gonna get? Probably gonna get a fair amount of my exam from the video, right? Because I'm watching them. And presumably, if I'm doctor here, I've got another doctor here at the bedside of the patient. So anything I can't see the patient do, I can ask the doctor to do. So, tap him on his knee. What's the reflex? Does he have one? Does he not? So I can get a lot of good history, I can get a lot of exam. What else am I going to need for my decision making? You guys ever had blood work done? Right. So I'm probably going to need some labs. So how am I going to get that?
Do the like store and forward kind of way that they put it in the system and then you can see it wherever you are.
So I could do store forward. So they're somehow going to send labs to me, probably put them someplace, and I have a computer here at my desk. And they've got a computer here at their desk. And so that way I can see the labs. Same thing with any imaging, you did it that way. It might also be possible, I don't know how often this is done, but say this is just too cumbersome, you can't quite set it up, there's no secure platform that serves as a third party somewhere in the middle. So it could be that I just log directly in. I've got my own little network ID and password, and I use a VPN, virtual private network access, and I just log right into the hospital and get the data. So it would be a possibility. So I've got lots of information about my patient in Missouri. I've had a chance through video, talk with the patient, talk with another provider there on site, meet the family, watch them, do the exam, anything I couldn't do, I asked the assistant there on site, Dr. A, to do for me. Got a lot of my data, my labs, even got a head CT that was sent over as well. So what is the outcome for the patient? What are kind of the three possibilities? It's kind of a guessing thinking. It's having a stroke, right? Possibility A. Yep, stroke. Possibility B. Not a stroke, right? Number 2. Not stroke. Sorry dude, bad headache, not a stroke. What about number 3? Is medicine always black and white? Never. Sometimes. Rarely. It's often not black and white. There's a lot of gray in the middle, right? So, golly, just don't know. So I told you, when my friend's doing this type of service, if he's able to say, yes, it's a stroke, and this hospital is able to treat, they feel comfortable with the treatment that's required, then they can move forward with that. Or, ideally, he probably says for a lot of them it's not a stroke, so you don't need to go forward with that treatment, and you can tell the patient not to worry, right? That's fantastic news. You don't have to transfer him, you don't have to worry about any additional follow-up thereafter. Bad headache, I'm certain, I'm a neurologist, I take that risk and make that statement. You're good to go. But then there's this. There's this place in the middle. And then what happens?
And they transfer to a neurologist in the area.
Right. So you can transfer. And now you've got Dr. Rodri here who's able to do the treatment or do additional testing. Maybe just needs to be in the same room with the patient to get a little more information. What happens if my doctor's not so good? We'll just say he's not such a good stroke doctor after all. He's still building his practice. And he has 500 patients who come into an ER. And he's able to say 10, stroke, no question, right? 10, not stroke. Don't worry about it, guys, it's all good. But then, he's got 480 who people having to transfer.
Yeah, in that case, it's like not cost efficient anymore because it's better to just send, because like you're wasting everyone's time at that point.
Absolutely, right? So beyond this, when we're thinking about where does healthcare going and how do we get from fee-for-service to value-based care, we need to also be asking some of this question and say, in the setting of telestroke, when I've got 3 pieces and I'm still not able to make a difference, make a good call, in much more than 90% of cases, it's probably not worth it. Unless I can say from a cost perspective that saving 20 patients being transferred is a big savings, at that point, I probably should go back to the drawing board and figure out something different, right? But what if it's reversed and this is 20 down here and I'm able to take a lot of people off the table? That's actually really good, right? That's a great use case for this type of service. And my guess is, even if my doc isn't very good, and at the beginning he starts out somewhere like this, over time, he's going to switch, right? He knows the practice of medicine when he's with a patient and seeing him in person and able to do that dialogue. And if he does 500 of these, he's going to start to pick up some of the subtleties and recognize a little more clearly, and recognize some of the workflow issues at each of these individual sites to be able to put the pieces together faster, or maybe even better. And it could be that over time, he's got wham, bam, thank you, ma'am. He's got a very succinct, clear, fast-tracked, easy way of making this assessment and making next steps happen. Okay? Let's go back to this scenario where I've got 480 patients that I've got to transfer to this hospital. And let's say that this is just one facility, it's just one extra transfer facility in any setting, right? If this is what's happening to date without telehealth, or if this is what happens with telehealth, I don't think that hospital's going to be too thrilled, right? But what needs to happen to get these patients that we're not sure of condition to this facility? Is a transfer an easy thing to do? No. So, if this is a facility that's not used to taking 480 of its 500 patients and sending them to a different facility, before I even think about doing this type of care, my proposition would be to figure this piece out first, right? I want to know what's the outcomes that I'm hopeful for and that I have, and I want to know this scenario, what happens? Stroke, you can treat on site, fantastic, taken care of. This scenario, what happens? Not stroke? Great, discharge, they go home. This scenario, transfer, I'm not doing my job by taking care of these patients if I don't know how this step is going to happen. Hopefully these facilities have already thought about that, right? Because it's probably already part of their standard workflow. But in some cases, when I'm working with new tools in mHealth, with remote monitoring, with extra data points and new devices and information, I may not have that workflow established yet. So the workflow clinically is huge when you're thinking about using this as a method of care delivery. Any other thoughts?
Going back to like the legal issue,
Yep.
I just had a question. Do you have any like suggestions, or how do you think we can make it easier for and create laws to, I mean, 'cause I feel like it's kind of trivial that laws are hindering like the progress of health or like access to health.
Yeah. It's difficult. It's really difficult. Because you want to think that everybody's going to do their best job and all the pieces are going to fit smoothly and all the workflows are going to be, one right after the next. But the reality is there's a lot of places where care can be fragmented and stuff can fall through the cracks. And I want to protect myself and protect those patients. In some settings, maybe no care is better than substandard care. And each of those states, I think that's some of their mindset. It's not just that, clearly, right? They want to make sure that at some point all of their doctors treating patients in Missouri haven't relocated to all the states outside for whatever reason, right? Maybe Missouri is super costly as far as medical malpractice or some other issue. Now all of the states doctors just up and leave because they know they can do the same care through telehealth. There are lots of pieces at play. Things that they're trying to do from the liability standpoint, they're trying to open up some reciprocity for medical licenses in certain states. So if I'm licensed in California, perhaps it's not a 6-month process for me to get licensed to do telehealth in Oregon, because it's real close by. There may be some agreement made between those states that they'll recognize one for the other. I think a lot of states are looking closely at their own patient populations, their own insurance structures, trying to decide what parts of telehealth they'll respect. So for some, I need to establish that physician-patient relationship first, and then once I've seen you in real time in the clinic, then we can move forward and do telehealth thereafter. Some have said that's not as big a problem for us because our access is so bad, we just need a doctor. Some have said I can see you online, but I can't prescribe you medicines. So I've got to work with some other clinician who's there local with you at your site or in your state to actually write the hand prescription. States have gone a bunch of different directions, so some of that's still being worked out. My hope is that at some point it will be a little more streamlined, and if nothing else, just very easy to see what the differences are. You guys, oh, go ahead.
Quick question.
Yep.
I don't know if you can tell the class, I don't know if you have knowledge or not, but do you know the history of why the US is so state-centric in its medical laws versus parts of Europe where are more relaxed about where you go to medical school, you get a medical degree, and lots of different parts will recognize that license. But in America, even though you have to take the MCAT, right? You gotta go have the same requirements. All medical schools pretty much meet the same requirements. The residencies are pretty much almost the same requirements, and yet the licenses are completely fragmented. What do you think the history is of that?
I don't know. Do you know?
I think for Europe, they have tried to become more integrated over time, you know, the EU and all that. And so they feel a little bit more comfortable, like if a patient goes into another country, whereas in the US, obviously there's a lot of like political ideologies that are very different, and states tend to like be kind of concentrated on their own thing, so I feel like that would be kind of the history piece there.
Yeah.
Again, politics.
Yeah, again, politics. Well, I can certainly say from a physician standpoint, there's a lot of resistance, I think, with some communities of physicians that I don't want this to come up, right? I know that if I've got my door open and my shingle hung out front, that I'm going to get a steady supply of patients. Well, what happens when somebody builds out this telehealth system? Am I going to be left with a good medical degree, a nice office space, and nobody wants to come visit me there and be treated and seen? So there may sound a little far-fetched, but there are some individuals who don't want to see any of this come up, right? They don't want to lose their patients. Some of that's that same kind of stronghold on practice, on individuals that they're seeing. Good. Are you guys aware of too many of the telehealth providers? I feel like in the Bay Area there's enough names and people that meet the general audience that you probably have heard of a few. Anybody? No? Has anyone heard of Teladoc? Yes? See some nods? What about Doctor on Demand? Yep. Ring-a-Doc I haven't heard as much from recently, but they exist. So those are quite a few. I think they do a large number of primary care, urgent care type care. Icebreaker Health, that comes from local roots. I do dermatology, so I work for a company called Direct Dermatology, but we're not the only dermatology group. So there are dermatologists on call, there's Spruce, there's iDoc24, First Derm. I feel like a lot of the time, the longer I go, the more I hear. We didn't talk about it specifically for dermatology, but when you're thinking about patients I see in the clinics, it would be intuitive to think that it's skin, it's visual. What more do I need, right? Got a nice picture. What else comes into play with skin health? Has anyone been to a dermatologist recently? So I would admit that a lot of what I do is based on things I see, but not everything. So I can see eczema, I I can see psoriasis, I can see warts, I can see acne, I can see skin cancers. This is the common stuff. I can see rash. Just like my neurologist. I see this. What are my outcomes? Eczema. Not eczema. Okay? If I'm building a workflow for telehealth, it looks like it's all visual. But what happens if I've got this? What do I do? Got this beautiful platform, the technologists and I got together, we set it up, it's HIPAA secure, we got through the liability, I'm providing my care, but I'm not very good at what I do. 480 of them right there. What do I do with them?
Two options that quickly come to mind are to like prescribe something and to see how it works out. And then the obvious answer is to actually have them come in so that you can do a biopsy or something to determine what it is.
Yeah, I would agree. That's basically the two big things I could do. The third is maybe find a consultant. Maybe I get desperate. Or, if I'm not too far away, maybe it's just 50 miles. I drive. I like driving, why not? Right, so I can just go there and I see them.
This is also where you can add supportive care, like nurse practitioners
Right.
partnering with you, right?
Yeah. Consultant, NPs, PAs, other derms, PMD. Maybe I just need to pick up the phone, talk to somebody and say, I need more information, help me out. So, I can prescribe and I can see what happens. And maybe wasn't sure it was eczema, but it responded nicely and it got better, so I'm okay. Patient's happy, I'm happy, didn't come back. Whatever it was, it's better. I can prescribe and it doesn't get better, right? Not better. Or better. So additional contingencies. My job is to make sure that before I jump too far into my muddy waters, whatever I'm going to see, I know how I'm going to handle the outcome. And I'm going to start looking over time and I'm going to say, well, these are my numbers. And so the data looks really good for some and not so good for others. I would hope it might look something like that. Right? So, eczema, love it. Let's treat eczema through telehealth. Good outcomes, I know how I'm going to handle my contingencies, I've got a plan for backup, and I do a good job. So let's do it. Psoriasis could be similar. Acne could be similar. Skin cancers, warts, rash. What am I going to do for warts? Wart. Not wart. No, no. Yep.
For certain health growths or like skin growths, don't you have to like take a sample and like run tests on it to see like if it is cancerous or if it is
Yeah.
just
Yes, I do. So, what happens for skin growths? For warts and cancer, because they're both growths, right? What are my numbers looking like?
Everybody's coming in. I mean, you're having everybody coming in anyways.
Bingo. Ah!
Or is there a way they can get their test taken somewhere else and then send that to you?
I would love that.
Yeah.
So, I don't know about wart, but skin cancer. What if I said, new test? Right? No cutting. Right? And very sensitive. May not tell me for sure that it's a problem, but it's definitely going to catch it if it is. I'm not going to miss too many. So, if I cut this, I can still do skin cancers that way. Because then I can make my numbers look more like this. Right? There's another benefit to doing some of this through telehealth. And that came back to, what is my goal with this method of care delivery? Am I managing? I'm taking care of the entire problem, wrapping it up, it's all done? Or am I triaging? Because from a triage perspective, it may be that, well, I want to catch these skin cancers and I know I've got to send them in. What I really want to do is I want to catch the bad skin cancers. I want to know the second I've got a melanoma, because that I've got to make arrangements for. I got to drive out there and take care of it. But there is some limitation. So this, I think, is going to be my job moving forward, is saying, along with my colleagues, where is this method of care delivery really a good service? Where does it actually provide some benefit to the community? And I think anybody who's looking at this type of remote monitoring, mobile health, video interactive, and asynchronous store and forward services should be thinking that way. Where are we actually making a good, positive difference? And where is it really just not working? And if we can't find a way to make it work by going back to the drawing board and figuring it out, then it may be that that's just starting clinic care that we give. I hope our healthcare system looks at this. And I hope we've got teams of physicians like you guys tonight who sat here and said, we're going to think about it. We're going to pick apart the problems. We're going to look at where it works really well, what are the benefits of it, and we're going to start incorporating data into our decision making so we can figure out how to build it out and make it a better part of our healthcare. And if you can tie it into a workflow where you've got some flow in and out, I think we'll have a really superb system. But it is not going to be easy to build. I think we're getting close. It's about 7:23. Are there any other questions? Anything else anyone wants to bring up? Thoughts from tonight?
Do you know of any groups or organizations that go through like this type of thinking on a regular basis, like brainstorming solutions to these types of issues?
Francis?
I couldn't hear the question, what was it?
Do you know any types of groups that do this type of kind of dissect the problem, pick it apart, see where it works, where it doesn't work? Is that your question? Yeah.
Well, Edge Insurance Policy does all kinds of projects like different networks, yeah.
Like a think tank of sorts.
Yeah.
I can guarantee they're happening at higher levels. Like I'm pretty sure that, you know, in some room where someone's writing the actual policy, there's a group of advisors who, you know, represent each of these different disciplines, either the medical board, the practice provider group, or the patient community, and they're doing it. I don't know.
One thing I definitely advise is like try to do some healthcare, what do you call it, hackathons or codathons. We do that constantly, and they're attacking the key parts of the problem. Trying to fix the healthcare system, as you can see, it's one big giant, huge, big boulder of a monster, and it has multiple parts. So the best thing to do is to find the ones that are critical, and don't like thinking, you know, don't, because you guys did this the last time where we were looking at some of your ideas. It's not about policies and the whole, you know, the politics of it. That part is going to have to kind of evolve itself, but that's basically the main problem. But as far as from a technical point of view and things we can do from an actual business point of view, because that actually moves much faster, attack those low-hanging fruits that actually have the actual critical points in there. Influence and show that they actually work, and eventually that will grease the wheels and turn faster in that direction. But from a top-down model, that's going to be very difficult. But from a bottom-up model, much more reliable. And can you tell us a little about yourself real quick?
Yeah.
Because I know that you have a very special story. She's one of the few doctors I've met that actually has two specialties coming out of residency at the same time. Most doctors only come out with one residency, but Andrew came out with two, and then you, as soon as you graduated from residency, you didn't go straight to becoming a full-on attending like most doctors do.
Right. Yeah, so what Francis says is true. I'm not a pediatric dermatologist, but I have 2 board certifications. So I did a combined integrated 5-year program at the University of California in San Francisco, and I trained in both pediatrics and dermatology at once. So just like every other intern across the country, I was in an internship program in one specialty, that was pediatrics. In my second year, I did a full year of dermatology, and then for my last 3 years, I kind of flip-flopped back and forth, every 6 to 9 to 12, just depending on rotations, number of months. when I finished, I knew I liked this, use this part of my brain, use that kind of part of my brain, going back and forth, and so I didn't sign on with a full-time position with any one place. I looked at a large number of places, but I went to everybody with the same request, and that was, I want to be in the clinics 3 days a week, I want to be doing something different 2 days a week. Looking at workflows, looking at data, looking at administration, how do we put the pieces together, how do we fix some of the big frustrations with the technology, how can we integrate it? And I wasn't able to find a buyer, essentially. A lot of frustration, I'll say, on my part is that as a clinician, as a physician, I'm very, very valuable to see patients for any employer I approach. So when I said I want to do part-time clinics and part-time something else, and there's lots of people that could do the technology or the statistics and the data stuff, and probably many of them as good or better than I could, it was a tough sell. So I couldn't find one position to do it. Right now, I'm working for Kaiser part-time on a per diem basis. I work for a corporate healthcare company that plans a big conference and brings big leaders together that have probably this type of conversation. And then I also spend a day a week doing just my own personal networking and outreach with a bunch of different projects I've got ongoing. So currently, I'm looking at work with the California Health Information Exchange, looking at how can I start flagging records for patients that need to be sent to a tertiary level center sooner and make that referral happen, chop chop instead of slower. And also looking at maybe informatics credentialing for the fall. Very cool. So lots of different stuff. But anybody in this room, choose your path, and it doesn't have to be the traditional. Doctors are going to be doing all sorts of things in the future I can't even predict. And when you finish your training in 10 years, 12, 15 years from now, you may not even have dreamt it or predicted it. So there's lots of stuff ongoing. You're smart, you're motivated, you're ambitious. Choose your path. And there's lots of things to do with healthcare. Cool.
Thank you so much.
Yeah.